Welcome everybody for coming. Thank you so much for being here today. I see you, Kristen and Trisha and Brandy and Kayla and Stephanie, and thank you so much. And again, we will record this and share this out as well. So this information will get distributed. So we just want to again, thank everybody for being here. Megan, you can go ahead and go to the next screen and we can identify and thank all of our sponsors. I'm not going to spend too much time on this page because we are already cut for time just a little bit, but really I wanted to get this kicked off, and thanks so much to CHI St. Luke's for being our presenting sponsor and our experts today. But most importantly, I want to turn this over to our host, Jim Parisi, the North Houston Market President for CHI St. Luke Health. And because he doesn't have enough going on, he's also the Montgomery County Board of Director member. So we do appreciate all of your time and support. But I'm going to turn it over to you, Jim, and let you kick it off with the introductions.
All right, Teresa, thank you very much. I really appreciate the opportunity to have a chance to talk to you all about women's health and the American Heart Association, and some really, I think, unique opportunities for all of us collectively to try to address. And as a board member, I appreciate everything that all of you on this call are doing every day to try to improve the health of our community. And there's lots of really great things going on. And I'm especially thankful that we have the opportunity to have these happy half hours and really focus in on different aspects that will make a difference in our community as time goes on. So I'm actually going to host this, I guess, today as the president here of the Woodlands. I want to introduce Judy Brown, and she is the director of our Women's and Infant and Children's Services here at the Woodlands, or Women's Services. And then Heather Lozado, who is also a registered nurse and an education specialist for our Women's Services team. And this one is really particularly important to me, I think, with COVID and all the additional pressure that all of us have felt, I think, over the last year or so. I think it's only exacerbated many situations in that many people have avoided care at all, right? So they don't want to go to the hospital. They don't really want to go to their doctor's office. They're afraid they might be exposed to something that they shouldn't be, even if we're doing, wearing masks and doing all the safe things. So a lot of people are really putting off healthcare right now. And I think it's particularly important to talk about it when we think about women. Obviously, I have a family, and my wife's a caretaker, and I have a daughter with special needs, and she, like many other people, have been seeing her doctor virtually for over a year now, and had a health event just recently, and now, realizes that she's hypertensive, and it's something that was sort of just kind of came up, probably something that would have gotten picked up in a doctor's office a little bit earlier. So I just think that's a good time to be talking about this. So I appreciate everybody coming together to listen. So I'm going to pass this on to Judy and Heather, and they're going to introduce this to you all.
Hi, everyone. Nice to be here. Thank you, Jim. I really appreciate it. When we think of the American Heart Association and hypertension, we really don't think of women's services initially or the pregnant patient. But I think it's really important that we do look at it because, as you know, hypertensive disorders of pregnancy are really a leading cause of maternal mortality worldwide. And unfortunately, if you look at this slide, you can see that the United States seems to be leading the way. And this is not a path that we want to lead. Hypertension in pregnancy is continuing to increase despite what we're doing, despite efforts. So we really need to speak about pregnancy and cardiovascular disease. And this is an excellent way to really raise awareness about this issue. When we look at hypertension during pregnancy, we are not just looking at hypertension, but we're really looking at a broad spectrum of related diseases. Sometimes patients are diagnosed for the first time. They've never had any issues at all, and it's diagnosed in pregnancy. Some examples of that might be preeclampsia, eclampsia, gestational hypertension, even going on to something called HELP syndrome or DIC. Or sometimes these patients actually have established medical disorders where they have chronic hypertension or they have renal disease. Pregnant patients also can have strokes or suffer cardiomyopathies. In general, we see about 5 to 10% of our pregnancies that are really complicated with hypertensive disorders. We also know that these diseases are under-recognized. And like you said, sometimes patients don't go get care. So we don't recognize it till later if they don't get prenatal care. And sometimes we don't see it until afterwards, and we see it in the postpartum woman. We also see a much higher incidence of this in the African American woman. So there is definitely disparities. We have also noticed that there's a real higher association of obesity nationally and internationally associated with this. So as the obesity rates continue to climb, we are seeing more of that, more of the hypertension. They kind of go hand in hand. Increased maternal mortality is also associated with eclampsia, this whole sequela of disease process that we see, this HELP syndrome. These patients can come in and they present with headache and abdominal pain, blurred vision, brisk reflexes, and sometimes very significantly elevated pressures. If we don't treat them and we don't recognize this very promptly, they can have significant damage to their liver, cardiopulmonary, and renal systems. Prenatal care is an excellent time for the patient to develop a relationship with the physician and to really begin to detect issues and catch things early. So it's extremely important that we stress that pregnant patients get prenatal care. Even now during COVID, you're right, patients don't want to come. And sometimes you can't catch everything virtually with all of the high-tech technology, but it's really laying on your hands on the patient to be able to see some of these things. If we find the patient has really good prenatal care, we can really improve outcomes and help reduce maternal mortality significantly. Next, let's see. I've been doing this for over 30 years. And I can tell you that I have seen many changes in nursing practice. Recent literature shows that hypertensive disorders in pregnancy are rising, and things have changed, and we have really had to change the way we practice to keep up with it. When I first was a nurse, you would never see telemetry on every single unit, every single room on an obstetrical suite. We have that now. All of our nurses are now ACLS certified. They have extensive EKG training and are really taught to recognize disorders. We work really hard. We practice drills and we use algorithms. We've actually staged classified hypertension, and we treat according to the stage, and we treat very quickly. The state of Texas has actually created maternal levels of care. And the whole purpose of this was to ensure safe treatment of pregnant women. They want to make sure that if a woman is pregnant in El Paso, Texas, she's going to receive the same level of care that she would in Houston. And obviously, depending on where someone lives, could determine significant outcomes. The stages are 1 through 4. A level 4 center is your big tertiary care centers where they have every subspecialty that are offered, places like downtown Houston, the medical center. Out here in the community, I'm proud to say that we have received our level 3 accommodation, and we are able to treat just about everything here. Patients that require significant subspecialties, we would ship to Houston to the level 4 facility. But to be a community hospital and to be able to treat all of these hypertensive patients here in our community will really help to improve outcomes. Heather's going to talk to you about some of the initiatives that the state is doing with these patients now.
Thanks, Judy. So yes, I'm really excited to be talking about this. I think this is something I'm really passionate about. And Texas AIM is not only, it actually is a Alliance for Innovation for Maternal Health. And so it's a big collaborative, not only here in Texas, but they're a big national movement, international, and even through the United States, because we do recognize that that the United States does have the highest mortality rate for our pregnant women. And why is that? So it really takes a lot of underlying factors for us to look at, and we need to change that. It's a movement that we need to change. So I feel like we're actually one of the first hospitals in the area to become a Texas AIM Plus hospital. And I'm really proud of that. We started probably back in 2018 with the AIM Plus. And so my theory is go big or go home. So we went with Plus. And so what does that actually mean? And so really back in 2018, we started looking at our processes, and looking at our outcomes, looking at our patients, looking nationally at the different algorithms and different order sets that were out there in order to give standardized treatment as well as the best outcomes for our moms. So being part of AIM Plus, we were able to implement different processes for timely evaluation of our patients, recognizing these patients and even treating them pregnant, whether or even postpartum. And so we treat these women not only in our OB department, we do have an OB-ED, but we also see them in our emergency department, our urgent care centers, our clinics. We've developed many different cardiovascular toolkits that really encourages women to be treated within 30 minutes. And we want them to be followed up within 7 days of discharge. So you can go back a slide. Okay, there we go. I was like, wait, where are we? Okay. So the first thing we started doing is by looking at these contributing factors. Like, what is causing our women to not, to not be treated or not be recognized? A lot of it actually had to do with the presence of underlying medical conditions, whether it was unknown or maybe they even knew about it, and maybe our obstetricians didn't know how to treat it while they were pregnant. And like Judy mentioned, the rise of obesity also contributes to those cardiovascular emergencies. And then I think naturally women delay seeking care. And especially during COVID, we don't want to leave our house. We just want to do telemedicine. And I completely hands down agree with Judy that, sometimes it's not the best, laying your hands on your patient, taking their blood pressure, it's really important. And then even the lack of recognition of those cardiovascular symptoms, okay? And that's not only for our physicians, but it's also even in those urgent care centers, our emergency departments. So I can say something I was really passionate about is educating our emergency departments as well as our urgent care centers. So I'm an ER nurse by trade. That's where I started. Same thing for Jim. And so I remember those patients coming in and, and wasn't really aware of things like that. But I actually go out to our urgent care centers and our emergency departments and give them information and education on those obstetric hemorrhages, on those obstetric emergencies, as well as hemorrhages, and those cardiovascular symptoms. I feel like a lot of times people feel like, especially those cardiovascular things can only happen while they're pregnant, but it's so wrong. It actually can continue even into the postpartum period, or even after that. So it's so important for us to improve that quality by educating all of our medical staff, including our ER doctors, our obstetricians, our cardiologists, for those pregnant women. And also to support our moms, okay, and support them through modifying their risk factors, encouraging a healthy weight loss, taking their blood pressure, stopping at the drugstore, taking their blood pressure at the grocery store, whatever it is. And just like Judy said, 24% of all cardiovascular pregnancy-related deaths were determined potentially preventable. So it's like, how can we as healthcare providers take that step to help prevent the next mom from this happening? That's 24 moms out of 100 that left babies behind, that left support people behind. So I think it's our job as healthcare providers to take that step and to improve awareness. So next slide. So like I said, this is a big collaborative nationally, but we've also taken the steps in the state to create toolkits. And these toolkits include many sections that include overview of clinical assessments, not only for our nurses and our physicians, but in different phases of care, whether it's antepartum, postpartum, pregnancy, for all those different phases. It also includes management strategies. If they have this risk factor, it puts them at this type of risk for pregnancy. What are their presenting symptoms? Their presenting symptoms are X, Y, and Z. That actually puts them at this type of risk. It also includes synopsises to inform those clinicians caring for these women about the cardiac disease and what the current resources and evidence-based practice say to give the best evidence-based care. It also summarizes necessary clinician and facility resources for treating women with cardiovascular disease. So just like Judy said, with the maternal designation, the designation that's going on throughout the state, the importance of this is that it's standardized. And so wherever you go, this is the standardized treatment that you'll receive if these are the symptoms that you present with, or if this is the type of disease that you have, this is the evidence-based practice that you'll receive. So it is standardized at each facility. And another thing that's really important, and especially in this time period, is the toolkits also include key points about racial and ethnic disparities. Because like she said, African-American women are more prone to hypertension. And so really including that within our assessment and our diagnostics. So next slide, thank you. And so again, these are some of our toolkit components that have gone national from, this one's actually from the California Collaborative, but, they've been able to share internationally and nationally, and we've been able to use these to improve our quality care. So it also includes information and infographics geared directly for women who are diagnosed with, as well as after their postpartum period, on how to be able to manage that, maybe about their next pregnancy, how to manage it then. And also for our obstetricians and even how to manage those future pregnancies. So again, I'm just super excited to bring this awareness to the population, to people, because again, just like Judy had mentioned, this is, we often look at pregnant women and think, oh, they're just healthy, they're going to have a baby. But our population has changed so much. And just like she was saying, how our nurses have, our nursing unit has changed. We now have the opportunity to provide tele. Just a few weeks ago, we had a pregnant lady who had, she had a pacemaker. And, that's something it's unheard of. Like, who would have ever thought, a healthy 28-year-old would have a pacemaker? But because of the education that our nurses have and the standardized processes that we have, that mom was able to deliver a healthy mom and left here healthy. Do you have any questions?
Well, thank you so much. I just, this was so fascinating. As we move through some questions, I'd love to share a little bit about what the American Heart Association is doing that I think might help us connect some dots and fill some gaps in care. And I'm so excited that we have Emily Paul on the call. She works closely with me on the community impact team and has just done some amazing work, even in Montgomery County with some for the program I'm about to talk about. So we have a national initiative with the American Medical Association that is all about controlling hypertension and working on quality improvement within the clinic. I bring this up because I think it's such a nice kind of a connection with this incredible work that you all are doing at CHI. And so I'll tell you the program that we are enrolling clinics in is called Target BP, target blood pressure. And, the idea is that for every clinic we sign up, we'll get 70% of their patients under control with their blood pressure. And this means, frankly, longer, healthier lives. When we look at what you've presented today, Judy and Heather, I feel like some of the maybe exciting areas where we could perhaps grow partnerships is, around the women that are maybe not captured in the system. I mean, I think you guys are just doing such an incredible job with quality improvement within your hospital to ensure immediately capturing any problems. Sometimes I'm concerned about the postpartum moms that are maybe they've fallen off their Medicaid coverage and they don't have a primary care provider. Maybe they're going to the OB-GYN for their primary care because so many of us are so busy and we don't have time to go to multiple doctors. So we just kind of show up once a year to our OB-GYN. I think some possibilities would be for us to provide blood pressure cuffs to some of these moms, to work with some patients, in particular postpartum population, to as part of Target BP, to see about really teaching them how to measure their own blood pressure because maybe they just don't have a way to even check. I'll rely on you guys to maybe correct me if I'm wrong about that. It seems like a lot of patients, there's some education that's needed there. And then also, I think in some of the work that we're doing with our community health workers, we're starting to work on trainings for community health workers to be able to capture some people that maybe just aren't keeping their blood pressure under control. But those are just a few things. I'm sure I've left off something. There's so much to say on this, but I'd love to kind of open it up for questions for Judy, for Heather, for us at HA.
I was just going to jump in, Judy and Heather. I have been so inspired by not only the content that you're sharing, but the passion that you're sharing it with. And, I know that the work that you're doing is impacting patients. I thought it was particularly interesting, Heather. I know you talked about, the postpartum piece. And I think, as from the patient perspective, it's easy to think, okay, I've had the baby, we're good, check that box and move on.
Mm-hmm.
And so as a provider, talking about what that looks like, I thought that was really interesting. And I appreciate you sharing that.
Absolutely. Even our discharge folders, they include information about those warning signs, like the headaches that don't go away, blurred vision, even like abdominal pain, because it can, even like Judy had talked about the HELP syndrome, it can involve the liver. And even, pregnancy in general, that's a lot of work on your heart. And so if women had an underlying heart condition that maybe we weren't aware of, that can easily send them in some type of cardiovascular complication later.
I have a quick question. I know we're supposed to be checking our blood pressure more than just when we go to the doctor, but I noticed last time I went to CVS, they've removed those little kiosks. What are we supposed to do in between if, at least in this new world, they're not there?
So yeah, we're encouraging patients to, get their own machine and check them at home.
Okay.
I do think that's a great question, Tracy. And I do think as we go through the pandemic and begin to reopen a bit, the aftermath will be a lot of people's chronic disease levels will be uncontrolled.
Mm-hmm.
We are going to see those downstream effects of people not getting care, not being able to touch something that's meant for a group because we can't. That's presumably why they've removed those from the CVS and from, for a while we weren't even able to use the playground. We weren't sure if we could even go out. Maybe we'll catch COVID. So it's just been really tough. I think we're going to see those effects in the clinic and in the hospitals. Jim, I don't know what your perspective is, but that's what I'm predicting.
Yeah, no, I think you're right. And obviously the concern for a lot of folks is they won't be able to afford to go buy an automatic blood pressure cuff. Some people will, not that big a deal. There's some really nice ones out there now that, have apps and interface with your phone and log your blood pressure. And, they're really very dependable. They're almost as good as taking it manually. But, you think about it, the cheapest way to go about it is to give everybody a manual cuff and teach them how to do it. But that takes some time. It's kind of like doing CPR. You almost have to have a clinic, if you will. But I do think you're right. It is going to change it. We have to really think about how we reprioritize, how we screen people, being very, very focused inside of all the clinics. I think the BP hypertension project that you guys are doing with the physicians' offices, all across, Texas and the country is really a wise thing to do. I'll just say this. One last comment is, Heather mentioned I worked in the emergency room for a long time. I'm a nurse by background, still have my license. Try not to go down to the ER too often anymore. But realistically, I've been involved in trauma systems development from the early days, 25 years ago. And I was there many, many times when any of your American Heart Association predecessors were there with us at the legislative sessions, essentially arguing that having a heart attack or having hypertension or having a stroke is just as important as, a trauma, and so we've done, and I think the American Heart Association has done a really good job of advocating for those things and sort of those levels of care across the state. And the reason why I bring all this up is because that's how we got to these maternal designation standards as well. So, you may not think the American Heart Association had anything to do with the level of designation for a maternity center, but you really did. It goes back 25 years ago or 20 years ago when everybody was there lobbying for the legislature to integrate this into the trauma systems development, and it's working, right? I mean, we have great comprehensive stroke centers and STEMI receiving centers and all these things. So we just got to keep moving further down the road. So I just wanted to, a lot of people don't know that, how much of a role the American Heart Association played there. So thank you all for that.
Well, Jim, I appreciate so much that not only that you have that historical knowledge, but I also, it makes me think about mentioning what you just said about our advocacy work. I talk a lot about the big things that we do and how that funnels down to the local impact of the mission. But, on a large scale, we have a complete department that handles advocacy, that works on healthier policies. They advise us to work locally on healthy policies. Judy, the connection for me when you talk about obesity as a driver for these preeclampsia issues and hypertension issues in women, the obesity alone is something that's going to be very difficult, that has been very difficult for us to get on top of, not only because of the stress, but look at the environment that we live in. And, never has a calorie been less expensive and cheaper and more accessible than it is today. All you have to do is go through the drive-through. But, I think on that note, the AHA has really pressed onward to get rid of things like sugary beverages. Maybe not particularly in Texas on expanding Medicaid, even though there's a dire need for it. But we've been working nationally to expand Medicaid to states. It's been such a struggle in Texas, but it's something we continue to work on, and we're really pressing forward on a national level as well to make that statement. In Texas, we're working on policies around training for telecommunicator CPR across the state, because we know that once someone is at risk for a heart event or heart attack, they need to be able to get the help that they need so that their loved one or their friend or whoever they're with as a bystander, they can really implement CPR right away, and that they can call 911 and know that someone has that training and can talk them through it. So these are policies that span across the state that we've been working on for a very long time. And thank you. I see a nice slide here. These are the 3 areas that we work on locally. So with the advocacy support that we get nationally and across the state, we are working locally, again, on things that we know that will build healthier communities. Nutrition security and healthy food access points, because we don't want people to get to the point where they are struggling with obesity. But if they can't get healthy food, how can they eat a healthful diet if it's not available to them? That these are the things that we could be doing to get people healthy before they get to the clinic or the hospital. So that's what we're working on locally. Hypertension, we mentioned Target BP. We actually have 100 clinical systems, 100 clinical sites signed up for our Target BP program. And actually CHI Baylor St. Luke's joined us in that, I believe it was last year. So very excited to have your medical group signed up. This, generally the patient numbers we're looking at that are served by those clinics is 1.25 million patients in Greater Houston. So
That's excellent.
yeah, yes, and we think so, and we are relentless about signing up more clinics. I will tell you, paired with the quality improvement that is happening in the clinic, similarly as what's happening in the hospital, there's a need for other things in the community to help with the obesity problem and to get people to be healthy. We are working on exercise prescriptions in certain parts of town. If we have clinicians that will work with us on that, we've been working on that. Very exciting stuff. And what this means is being physically active outside of the clinic, because you're with your doctor for, I don't know, maybe if you're very lucky, maybe 40 minutes. I'm not sure, but that's just one little sliver of time. You need to be active outside of the clinical visit. So we've been working on that. And then we also work on women's health, which was the topic for today. So anyway, so Megan, I don't know if you were going to talk about this slide, but it prompted me to talk about our local work, and I will be quiet there.
Well, I love it, Larissa. Your work is really impactful, and it's really interesting hearing from our friends at CHI how it all we all partner and work towards the same goal. So I appreciate y'all being here.
I love the idea of the hands-on CPR. I think that's so great.
Yeah.
I was like, I feel like I'm seeing more and more of those little stands in the airport and just the mall, just random places about hands-on CPR. I remember the first time I ever saw it, and I actually took a picture of it and I sent it to my husband, and who's also a nurse. And I was like, hey, look at this. Because I think that's great, because there are so many people that don't know it. But like you said, that's if your bystander or the person you're with happens to know CPR. It really does improve your chance of outcome. And but I love that.
Absolutely. We're super excited. So as this screen kind of says, we're going to be having some of these conversations, and we're really excited. So please, mark your calendar, mark your friends' calendars. All of these topics are really, really relevant to our community, and the more we can share this information with, the better outcomes hopefully we'll see.
You're absolutely right. And truly, with No Heart Bowl that we're celebrating this year, these kind of conversations are so important. And so we appreciate everybody kind of coming around the table with us and being a part of this continued work. I know we are out of time just about. So I want to kick this over to Jim to wrap us up with some housekeeping. But again, thank you all for being here. Thank you to our sponsors again for being a part of this. We really do appreciate it.
All right. Well, again, thanks, Judy, and thank you, Heather, and of course, everybody that's made comments or asked questions. We really appreciate the engagement here and making a difference for our community, which is really all that we're all here for. So there's really just kind of a last request. If you feel like it's something that you can do, we have an opportunity for you to give to the American Heart Association here at the end. You can see there's text heart of MoCo to 4144. 4. I got that all right, all the 4s in a row. And of course, the sponsors again, US Anesthesia, we're there, CHI St. Luke's, and of course Memorial Hermann the Woodlands. And our bronze sponsors, Kiewit, they're always there. It seems like they're always here helping us. Kitchell Contractors, Texas Children's, and then of course Wood Forest. Christy, thanks for being on. I saw you on there too. So, but again, we look forward to seeing more of these. I know there's 4 more coming, and we will. I guess we'll see you all soon.
Thank you all so much for your support and your time today.